My name is Agnone, and I'm a gastroenterologist at the Borland Clinic. A lot of patients get referred for screening colonoscopy, and March was colon cancer awareness, and of course we're making a big push to teach people about the values of colonoscopy in preventing colon cancer. But a lot of times I'll get patients, especially males over the age of 50, who've had heartburn for a lot of years. And they weren't referred for that, but they had enough heartburn that they warranted an upper endoscopy to screen for Barrett's esophagus. And I've had quite a few patients over the years that their colons turned out to be okay, but they had Barrett's, and some of them had early cancer. And one of the nice things about detecting that early is that we now have some novel treatments where you can cure them endoscopically without surgery. 20 years ago, a lot of those patients would have had to have their esophagus surgically removed, and nowadays we have advanced therapeutic endoscopists. Many of them are in the Borland Clinic who can treat those people without surgery. Barrett's esophagus is it's a change in the lining of your esophagus. The esophagus is normally lined by what's called squamous epithelium, which is a lot like your skin. And in Barrett's esophagus, you get a change to an intestinal type lining. And you can recognize it looking at it through the scope because it has a different color, different texture to it. It occurs most commonly in Caucasian men, but anybody can get it. I have female patients with it and non-Caucasians with it, but I think 70% of it is in Caucasian men, especially who've had heartburn. And a significant heartburn history is generally thought of as at least 2 or more times a week, for several years in a row. And also other risk factors are, being overweight, smoking, and over the age of 50. I definitely recommend those people get screened for Barrett's. Usually if they do not have it at that point in their life, the odds are extremely low that they'll ever get it. But if they have it, then at least they know about it, and then if they do develop the signs of cancer, we can treat it early. They can go in with the scope and they can do endoscopic ultrasound where they get right up close to the tissue and they can take pictures to see how deep the lesion goes, and that helps guide whether or not they can remove it safely. Then they can go in and do what's called endoscopic mucosal resection, where they can raise the tissue up with a little fluid and then snip it off. And then the third thing they can do is they can ablate the tissue, and there are different thermal devices that have been devised. Probably the more common one that's used now is called radiofrequency ablation. And it's all done with the scope. Patients come in as an outpatient, can usually go home the same day. 20 years ago, a lot of these patients with high-grade dysplasia would have had a major operation. And this, is just another one of the marvels of modern medicine.